Hi, my name is Whitney Hansen. Today I'm going to talk to you about hyperbilirubinemia in the newborn. And this is for all my new hires in the NICU. I know some of you have NICU experience, but for some of you, you're brand new to the NICU. At the conclusion of this presentation, you should be able to identify the causes, list the signs and symptoms, identify appropriate measures for treating, and identify the importance of treating hyperbilirubinemia in the newborn. Hyperbilirubinemia is also referred to as jaundice, and jaundice is the yellowings of the skin and the white parts of the eyes. This yellow color is caused by the increased bilirubin in the blood from breakdown of hemoglobin. This typically occurs because the baby's liver isn't mature enough to rid the bilirubin from the bloodstream. Bilirubin is excreted in bowel movements and urine. So infant jaundice is very common. Approximately 60% of full-term babies and 80% of preterm babies develop jaundice. It's particularly common in breastfed babies and babies born before 38 weeks. So our premature babies are going to be more at risk. Um, Babies that have had significant bruising during birth, bruising causes breakdown of more blood cells, which can raise the bilirubin level. The blood type can put the baby at risk if the mother's blood type is different from the baby's. It can cause abnormal rapid breakdown of the red blood cells. Breastfeeding babies and babies of East Asian descent are more at risk. There are some other causes of jaundice, such as internal bleeding, sepsis, infections, a liver malfunction, biliary atresia, an enzyme deficiency, abnormality of red blood cells, thyroid dysfunction, or cystic fibrosis. So neonatal jaundice can be broken down into two different groups. So we have the unconjugated hyperbilirubinemia and the conjugated hyperbilirubinemia. So the most common that you're going to see most of the time is our unconjugated. This accounts for 75% of our cases. And typically you're going to see this after 24 hours of age. So our conjugated is least common, and you are going to see this within 24 hours most often. Um, and usually this signifies an underlying medical or surgical cause. So particularly with your conjugated hyperbilirubinemia, it's critical there's prompt evaluation and treatment. It also can be caused by impaired hepatobiliary function, and this could be an obstruction, an infection, or genetic causes. So as I mentioned before, one of the big signs of jaundice is the yellowing of the skin and the whites of the eyes. These babies are going to be pretty yellow typically. They also may have poor feeding, lethargy, a distended belly. They may have decreased output, temperature instability, or a fever. So you're going to confirm this by doing a blood test to measure the bilirubin level. Not all of these symptoms are needed in order for a baby to have jaundice. So hyperbilirubinemia is confirmed one of two ways. We have our TCB, which is usually done after 24 hours of life, and this is something your provider will put an order in for. But you're going to scan the baby's chest or forehead, and if the number is elevated, then you're going to want to follow up with a serum bilirubin. And again, your provider will write an order for that. So the bilirubin, you're going to draw that through a heel stick, but you may also be asked to do a CBC, a blood typing cross, You're going to check your Coombs test to make sure mom and baby don't have, different blood types. And you also may do a blood culture to rule out sepsis. Once you have your bilirubin level, you're going to give the results to the provider. The provider is going to enter it in our Billy tool. So this is a tool that's based on the AAP guidelines for 2022. And they're going to enter the baby's birth date and time, the sample date and time, the age of the baby. They're also going to put in the gestational age or if there are any risk factors. Um, this tool will then provide recommendations on whether phototherapy is needed, or it will also help to determine when a bilirubin level should be checked for rebound after stopping your phototherapy. So there's two main ways to treat hyperbilirubinemia, and this is with phototherapy. It's the most common. So you can do this with overhead blue spectrum lights or the fiber optic blanket. So what this does is it transforms the bilirubin into isomers that can be eliminated. The light needs to be in direct contact with the baby. So I have my baby here, and I just wanted to point out that oftentimes our babies are quite small, and it's not uncommon for the diaper to cover most of their body. So one thing you want to make sure that you do is make sure that as much skin as possible is exposed. So you want to tuck this diaper down so the back has optimal exposure. This baby does not have safety goggles on, but of course you definitely want to have those in place because those lights can be quite bright for our little babies. Typical treatment can be 2 to 3 days, but it's not uncommon for babies to rebound. So they may come off of phototherapy and then have to go back on for a day or so. So it's always nice to kind of forewarn the parents so they're not surprised if their baby has to go back under the phototherapy lights. In the NICU we use the Neo Blue, and we can do single, double, or triple by adding or taking away phototherapy lights. It's also important that the baby doesn't have any clothes on. We need direct contact with the light on their skin. So we're just going to take a minute to watch this quick video on how to check irradiance on the BiliSoft. So now we're going to take this opportunity just to do some hands-on learning and play. So we're going to take 10 minutes. We are going to play with the phototherapy devices. I have the Neo Blue. Um, I have the fiber optic blanket. We have goggles. I have the TCB reader. So we're just going to kind of play around so that when you have a baby that needs phototherapy, you know how to use it. So another way to treat hyperbilirubinemia, it's pretty uncommon for our NICU, but it's always nice to kind of have this in the back of your mind. In more severe cases, which is often your conjugated hyperbilirubinemia, you may need to do an exchange transfusion. And you don't have to worry, you will have lots of support. Providers, other nurses will be there to help you should this be necessary. But what you're going to do is basically replace the elevated bilirubin blood in the baby with donor blood that has normal bilirubin levels. So some of the things we can do to help avoid jaundice in our babies or lessen the severity is we're going to increase their total fluids. So if they're on IV fluid, we're going to bump up the IV fluid. We may need to supplement with formula and increase breast milk feedings. And this is just to help the baby stay hydrated and promote urine and stool excretion. We're going to make sure we're monitoring frequently for signs and symptoms of jaundice. If you suspect, this baby's looking pretty yellow, I think they may have jaundice, bring it up to the provider and they can order a bilirubin test or have you do a TC Billy. So why do we treat hyperbilirubinemia? Bilirubin is toxic to the brain. So if the jaundice is severe enough, there's a risk of the bilirubin passing into the brain. So prompt treatment may prevent significant lasting brain damage in our babies. Thank you all so much for listening to this presentation. I hope that you feel at ease when you come across a baby that has jaundice or may need phototherapy. You can always find more information on the hospital's intranet page and feel free to ask questions. Thank you.